I would hand the presentation over to David A. DeMora. Ms. DeMora oversees the National Initiatives Division of the CSG Justice Center. In addition to working with legislators, consultants, researchers, analysts, scholars, practitioners, and policymakers to help raise the level of public awareness about critical criminal justice issues, the National Initiatives Division provides technical assistance to more than 400 grantees of various federal grant programs, including the Second Chance Act, which supports the Justice Center, National Reentry Resource Center, and the Justice and Mental Health Collaboration Program. Now for Mr. Moram.
Good afternoon, everyone, and welcome. This webinar is going to review the Council of State Governments Justice Center report, Adults with Behavioral Health Needs Under Correctional Supervision, a framework for reducing recidivism and promoting recovery. It was released on September 27th. The report is written for policymakers, for system administrators, and frontline service providers who are committed to improving outcomes for men and women with behavioral health disorders that cycle through the criminal justice system. The framework introduced in the report can be used at the corrections and behavioral health systems level to prioritize scarce resources based on objective assessment of individuals' risk of committing a future crime and treatment and support needs. The presentation will begin with opening remarks by Commander Anita Pollard, Lark Wong, and Ruby Kozelbash. Pollard is Corrections Health Manager at the National Institute of Corrections. Prior to joining NIC, Commander Pollard served as the National Health Services Recruiter for the Federal Bureau of Prisons. Dr. Lark Wong is a Senior Advisor in the Office of Policy Planning and Innovation and the Director of the Office of Behavioral Health Equity for the Substance Abuse and Mental Health Services Administration. Dr. provides leadership on federal national policy pertaining to mental health and substance use issues for children, adolescents, and families, and also the agency lead on cultural competence and eliminating disparities. Kozelbash is the Associate Deputy Director for Justice Systems Policy at the Bureau of Justice Assistance. Ms. Kozelbash directs policy and national programs in the areas of substance abuse and mental health and corrections. Following these opening remarks, Dr. Froscher and I will present on the Adults with Behavioral Health Needs Under Correctional Supervision report. Dr. Froscher oversees the health components of the CSG Justice Center's initiatives. He also provides the technical assistance to state and local governments across the country to improve their response to people who have mental health and substance use disorders and are involved in the criminal justice system. We're excited to have all of these folks here today and look forward to sharing this information with you. Today's presentation will consist of three components: opening remarks, as I mentioned, followed by a brief discussion of the Risk-Need-Responsivity Model in behavioral health, and discussion of the actual framework for corrections and behavioral health. And we'll have some time left at the end for questions and answers. The report on the Criminogenic Risk and Behavioral Health Needs Framework was supported by the U.S. Justice Department's National Institute of Corrections and Bureau of Justice Assistance, by the U.S. Department of Health and Human Services Substance Abuse and Mental Health Services Administration. I very much would like to thank them for that support. We will begin now with some remarks by Commander Anita Pollard.
Good afternoon. The National Institute of Corrections recognizes the care of inmates with behavioral health disorders as top priority for the nation's correctional systems. Criminal administrators and practitioners want to reduce recidivism and the costs associated with evidence-based practices, which yield improved outcomes for all. Our solicitation in February 2010 focused on those adults incarcerated in our nation's prisons and jails, as well as those adults under correctional supervision. Our support of the framework is indicative of the need for corrections to have comprehensive tools that guide practitioners through effective decision-making, program planning, and treatment. The framework is one of the many methods and processes that will aid in this endeavor, and we are pleased to be a part of these efforts. On behalf of the NIC, I would like to express our deep appreciation to our associations and advisory group members for their steadfast participation. These include the following: the Association of State Correctional Administrators, the National Association of State Alcohol and Drug Abuse Directors, National Association of State Mental Health Program Directors, the American Probation and Parole Association, Mr. Steve Allen of the Minnesota Department of Corrections, Director John Baldwin of the Iowa Department of Corrections, Tanya Brown of the North Carolina Department of Health and Human Services, Dr. Nelson of Arizona Department of Health and Human Services, Doctors Jennifer Skeem, Baxman, and Ed Latessa. Would like to thank our federal partners, the Substance Abuse and Mental Health Services Administration, and the Bureau of Justice Assistance. Including a final thank you to the Council of State Governments Justice Center for their entire efforts to ensure that this framework would come to fruition. Thank you again.
This is Laura Wong from the Substance Abuse Mental Health Service Administration. I'd like to echo Commander Pollard's thank you to the various partners involved in the development of this framework, and particularly our partners at National Institute of Corrections and Bureau of Justice Assistance. It's been terrific collaborating with you at the federal level on this very important work. So at SAMHSA, our work is guided by 8 strategic initiatives. They're shown on the slide there. The second strategic initiative is focusing on trauma and justice. Each one of these initiatives, created by our administrator, Pamela Hyde, is led by one of the senior leaders at SAMHSA. These initiatives guide us in our planning, our programs, our policies, clearly our budget decisions in terms of how we want to provide leadership in each one of these areas and how we feel they are critical to the overall mental health, behavioral health, well-being of people in this country. This initiative on trauma and justice is the only strategic initiative to actually call out a particular system. The 8 initiatives all focus on the behavioral health, mental health, substance abuse system. This is the only one that calls out and focuses on another system outside of behavioral health, and that is the criminal and juvenile justice system. So our purpose in this particular strategic initiative is not only to look at trauma and understand the centrality of trauma in mental health and addiction disorders, but to also better address the needs of people with mental health and substance use disorders involved with or at risk of involvement with the criminal and juvenile justice systems. Our reason for that is really understanding the high rates of disorders that we are tasked with addressing, mental illness and substance use and co-occurring disorders, by prevalence and high rates of those disorders among people who are in the jail and prison populations or at risk for entering incarceration. We know that there are over 700,000 criminal justice offenders re-enter communities from prisons each year. And to reduce recidivism or reoffending, we feel it's imperative to also address the behavioral health issues that those offenders bring back with them into the community. We know that about 2/3 of meet criteria for substance abuse or substance use dependence, but probably less than 15% receive treatment after incarceration. We know that about 24% in prisons have a recent history of mental illness, yet only about 1/3 of them receive treatment after entering incarceration, and also have difficulty receiving treatment upon reentry to communities. So this is a system that very much interfaces with the behavioral health issues that we as an agency are very concerned about. So therefore the importance of really collaborating with our federal partners as well as strategies for really looking at how do we cross the silos of questions of mental health and substance abuse. And I think this framework and the partners involved in developing it have done a terrific job of crossing what have been traditionally difficult to cross silos. Also working in a new policy environment with the usage of health reform, the Affordable Care Act. We know that in the year 2014, 32 million more people will be covered through expanded Medicaid or commercial insurance or health insurance exchanges. We also know that anywhere from 6 to 10 million of those new people to be covered also present with mental health and substance use disorders. That also has implications for how we work with the criminal justice system. We know that the Affordable Care Act can present new opportunities for the justice-involved population. That there will be more wider coverage expansion, meaning that individuals re-entering communities from jails and prisons who in the past have not had coverage or timely health coverage in the past will have more opportunities for coverage. We know that the criminal justice population with comparatively high rates of mental health and substance use disorders will now have an opportunity to get more coordinated health coverage with other efforts and to increase successful transition back to the community. Addressing behavioral health needs, we know, can contribute to reducing recidivism, reducing expenditures in the criminal justice system, while at the same time increasing public health and safety outcomes. Know that individuals who are incarcerated while awaiting adjudication of charges also can enroll now in the states that choose to have state health exchanges and expanded Medicaid, and that SAMHSA, as well as its partners in the justice system, are working to develop standards and improve coordination around coverage expansions for this population. We strongly support the development and now the dissemination and uptake of the framework that will be presented to you today. We think it brings critical partners together, that is, partners in corrections and substance abuse and mental health, that it provides a systematic approach for better articulating and coordinating the services across each of these systems. The framework gives us an approach to a shared decision-making and a structure to better integrate the separate approaches in each of these systems and to begin to get the right people into the right services at the right and the appropriate time. It will compels us to consider systematic assessments that are become accessible across these different systems, in language understandable across our different partner systems for more effective and efficient resource allocation. So we've been very pleased to partner with CSG, BJA, and IC in this webinar and in further rolling out this new behavioral health and corrections framework. Thank you.
Thanks, Lark. This is Ruby Kuzelbush with the Bureau of Justice Assistance. I think clearly the collaboration that you're witnessing really stresses that it's both behavioral health and criminal justice professionals that feel so strongly about improving outcomes for people with behavioral health needs and really making the most of scarce correctional resources. With tightening budgets and more information on what works, the conversation is shifting. It's more about getting, as Lark has said, getting the right people to the right services at the right time, and the framework provides jurisdictions with the context of that conversation and to do that planning. I think it prompts practitioners to ask, how are we right now assessing people under supervision for their risk of reoffending and their criminogenic needs? How are we right now allocating our resources? Do they match up? The framework starts states and local communities on that conversation and down the path of reserving and investing the most intensive resources for the high-risk, higher-need population and not doing harm or wasting resources by over-supervising or loading up lower-risk folks with services that they don't need. BJ has got a history of supporting innovation to improve outcomes for people with behavioral health disorders who are involved in the criminal justice system. Some say mental health and substance abuse, rather mental illness and substance abuse are the greatest predictors of incarceration, and that's a pretty broad statement, and it's based on an aggregation of laws, on policies, but perhaps most importantly on practices. And while the framework focuses on adults under correctional supervision, we've also got to understand the importance of assisting states and localities in changing practice
where it makes sense to divert people from corrections when appropriate, and BJA makes a lot of resources available through a number of avenues. For instance, we administer the Justice and Mental Health Collaboration Program, which is a grant program that funds collaborative efforts between criminal justice and mental health service agencies to make change really anywhere needed on the criminal justice continuum. We also support a number of law enforcement initiatives, including curriculum development and training on specialized police-based responses, for instance, crisis intervention teams, and support a host of problem-solving court initiatives and programs. We operate the drug court program, which includes training on how to best serve people with co-occurring disorders in drug courts, and also are supporting curriculum development for mental health courts, including on help in determining whether your community could benefit from a mental health court and how to plan and implement such a court. There's a lot of technical assistance that goes along with those programs that's available through BJA. We've got a strong focus on stopping the revolving door of justice and providing assistance through the grant programs that I mentioned, but also through conferences, training, and technical assistance. And we've supported and made a renewed commitment to recidivism reduction. Through the Second Chance Act, we support multiple grant programs that focus on reentry, and two of them have a heavy focus on treatment, both in pre- and post-release settings for people with substance abuse or co-occurring substance abuse and mental health disorders. And last December, BJA, with a number of partners, primarily the Council of State Governments Justice Center, sponsored a conference centered on recidivism reduction. And this year we made challenge grants to 7 states to make statewide reductions in their baseline recidivism rates. Those states are Arkansas, Georgia, Kansas, Louisiana, New York, Ohio, and Rhode Island, and we're excited to begin work with those states. And lastly, we place a strong emphasis on collaboration, which I think is exhibited here. This work we're talking about really lives at the intersection of public safety and public health, and we couldn't do what we do without our DOJ partner in the National Institute of Corrections and our behavioral health partners at the centers at the Substance Abuse and Mental Health Services Administration. But most importantly, we needed to hear from practitioners like you, and we accomplished that by partnering with key associations that represent many of the folks participating on the webinar today. So primarily the Association of State Correctional Authorities, the American Probation and Parole Association, the National Association of State Mental Health Program Directors, the National Association for State Alcohol and Drug Abuse Directors. And we most certainly look forward to continuing to partner with those associations. So thank you much, and I will hand it over to Fred Osher.
Thank you, Ruby, for those comments. Thanks to all of the federal for their guidance and leadership throughout the process. I want to now move into a discussion of Risk-Need-Responsivity Model and behavioral health, and followed by a brief presentation of the framework. As Dr. Wong had suggested, the overrepresentation of people with behavioral disorders in the criminal justice system is well documented. This slide we see from a study done 2 in Maryland and 3 in New York, over 20,000 inmates interviewed, that the rates of disorders for mental illness, look at the jail figures, male and female, are 6 times those rates in community, and particularly the 31% of women booked into jails meeting criteria for serious mental illness is something that gives us all cause for concern. The same is true for alcohol and drug use disorders, a significant factor but in the entrance to aggressive settings and complicating release from and stability within our community. And within this slide, we see that with broken out by alcohol use disorders and drug use disorders, 6 times more prevalent alcohol in jails and prisons than in the general community, and drug use 25 times more common in jail and prison settings, directly related to arrests for possession and sales, and again, a factor that complicates reentry and stability within our community settings. And these two overlap in not a random fashion, so that if you have a mental illness, you're 4 times as likely to have a substance use disorder, and a substance use disorder 4 times as likely to have a co-occurring mental illness. Here we see within general population and a jail population. In general population, about 25% of individuals with serious mental illness meet criteria for a substance use disorder. In jail population, it reaches almost 3/4. and this is true for both men and women. At this point, I'd like to turn it over to David Demora to discuss R&R, risk-need-responsivity, and how it relates to behavioral health. David?
And I apologize, but I'm not able to move the slides. Miranda, can you take it back and do it? Yep, they were just kicked in. Sorry about that. So before we move into talking about the framework, we want to talk a little bit about the risk, need, and responsivity model as a guide to best practices. Remember, we're talking about folks with mental health issues and substance use issues who are in the criminal justice system. And the most effective organizing frameworks in terms of thinking about working with folks in the criminal justice system has been now for a period of time the Risk-Need-Responsivity Model. It's backed by a fair amount of research and a lot of support, and is really one of the most effective ways to tailor interventions to folks who are in the criminal justice system. The risk principle really talks about matching the intensity of individuals' intervention to their risk of reoffending. So the amount of time that we spend, the nature of the intervention, the frequency of it, the intensity of it, is all based on what is their level of risk of reoffending. The principle talks about targeting criminogenic needs, such as antisocial behavior, substance abuse, antisocial attitudes, and criminogenic peers. What are the types of things that relate to the individual committing criminal behavior or recidivating, and what things that we can then respond to, that we can work with folks to change in order to lower the likelihood of recidivism occurring. And then the third principle in the model is called the responsivity principle, and there are in fact two components to the responsivity principle. There's the concept of general responsivity. And general responsivity simply says that what the evidence supports is that the most effective responses to folks who are acting out in a criminal manner is the utilization of cognitive behavioral interventions. Specific responsivity talks about the issue of tailoring the intervention to the different types of issues or styles that the individual may have, tailoring the intervention to their learning style, to their degree of motivation, making sure that cultural and ethnic issues are looked at, to their demographics, and the abilities of the offender, including their intelligence and including issues that might affect responsivity, such as, for example, mental illness. What do we mean by criminogenic risk? It's important to understand that criminogenic risk does not equal the type of crime, that it does not equal the issue of failure to appear, that is a different type of risk, that doesn't equal the sentence or disposition that is given to the individual, and that it is not the same as the custody or security classification level that the individual may receive if they are incarcerated. When we talk about criminogenic risk, is very specifically how likely is the person to commit a crime or to violate the conditions of supervision. And it's important to remember that this does not have to do with issues of dangerousness, that there are other different measures to determine dangerousness, that what we're talking about here is the issue of likelihood of reoffense or violation of conditions of supervision. So what do we look at? How do we measure the risk? Well, what we're measuring are the conditions of an individual's behavior that are associated with the risk of committing a crime. And there are two kinds of factors that are looked at. Static factors, which are essentially historical or unchanging conditions, and dynamic factors, which are conditions that change over time and are amenable to treatment and to supervision interventions. And indeed, dynamic factors are where we will spend most of our time when working with folks. Risk factors include such items as the criminal history, what are the number of past arrests, what are the number of past convictions, type of offenses, what are the current charges, how old was the individual at the age of first arrest, what is the current age, typically under 25 versus over, and of course also gender. The static, what that means is that when you're doing your initial case planning and thinking that this is information that's very important to make some initial decisions and determinations, but they are by definition definition, unchangeable with the exception of age. If you happen to catch somebody right on the cusp, they are essentially unchangeable. And so as time goes by, these are not the same factors that you would be, one, attempting to change, or two, be able to measure. What we would be looking at would be what we'll be looking at are dynamic risk factors. Now, in just a few moments, Dr. Osher is going to talk specifically about how behavioral health has addressed dynamic risk factors. But before he does that, let me just generally tell you a little bit about dynamic risk factors. And as you can see on your screen, there are a number of very significant dynamic risk factors. Again, remember, dynamic risk factors are those that are changeable. Things like antisocial attitudes, antisocial friends and peers, antisocial personality patterns, which, by the way, is distinct from antisocial personality disorder. Someone may or may not have that, but far more folks that we work with in the criminal justice system will have antisocial personality patterns as opposed to a diagnosis of antisocial personality disorder. Substance abuse, family and or marital factors, education, specifically lack of education, poor employment history, lack of pro-social leisure activities. These have all been shown to have a relationship to the likelihood of recidivism, and they are all dynamic or changeable risk factors. So each dynamic criminogenic risk factor has an associated need that is connected to it. In other words, if you have this particular risk factor, what is it that you want to do in order to ameliorate that risk factor? If you have a history of antisocial behavior, for example, we would work with folks to build alternative pro-social behaviors. If you have antisocial personality pattern or antisocial problem-solving styles, basically, then you would look to develop pro-social problem-solving skills, perhaps give anger management or a variety of other types of educational problem-solving curricula that help individuals resolve issues in a pro-social manner. If folks have antisocial cognitions or risky thinking, you work with them to develop less risky thinking. Antisocial attitudes, you want to develop and increase their relationship with folks who have pro-social attitudes and reduce their association with folks who have criminal attitudes. If there's family or marital difficulties, you want to help them develop and build positive and, again, pro-social relationships. Poor school or work performance, you want to assure that they have the correct training. You want to enhance their performance. You want to make sure that the appropriate rewards are available, and rewards in terms of it being real work, rewards in terms of being appropriately paid for that work. If you have few leisure or recreation activities, then you're looking again to enhance the external or outside involvement with folks. And once again, it's important to remember that we're looking to enhance those activities in ways that are pro-social or positive. And then finally, at the bottom, you see substance abuse. And the issue there, of course, is reducing their use or abuse through integrated treatment. One of the things that's important to remember is that many of the risk factors exist because the individual is attempting to meet a variety of needs, often typically the same types of needs that the rest of us are trying to meet. But because they are so antisocial in their thinking and their style and their problem-solving ability, the ways that they attempt to meet those needs are problematic and criminal and cause them more difficulty, and in fact, ultimately, they end up not meeting their needs in any successful fashion. So with that, I'm going to turn it back over to Dr. Osher, who will specifically talk about how the behavioral health system has historically addressed some of these dynamic risk factors.
And it is the case that just as there's an overrepresentation of persons with behavioral disorders in the criminal justice system, so that the people that seek care within our substance use or mental health environments, they have a overrepresentation of involvement with the criminal justice system. So not that this is a new population to work with. It's been a population within our clinical groups since we've opened our doors. In the case that the mental health system has focused with effectiveness on the bottom four highlighted in green factors that are a part of the dynamic risk set. And this is bread and butter for mental health clinicians intervening, thinking about how to assist an individual with their family or marital problems, their education, employment, and leisure skills. It has been more recently that we have seen ability for that set of persons also to bring in individuals with co-occurring disorders and focus on the reduction of use and harmful consequences from the abuse of substances. It's been the mission of our addiction providers to address substance abuse, so that by they have historically looked at one of the key risk factors for returning to jail or prison. These top three, antisocial attitudes, friends, and personality patterns, that neither group has particularly focused on and that have brought the full skill set of those providers to bear on changing this set of dynamic risk factors. Indeed, the more dynamic risk factors that the individual has and that are focused on by interventions, the less likely they are to return to jail and prison settings. We talked about mental illness, and it's not in that list, as you see, as one of the top explanatory factors for people returning to jail and prison. Incarceration is not typically a direct result of mental illness. Some for that is derived from this study of over 100 individuals with schizophrenia spectrum disorders in a jail diversion program in Hawaii. They've had extensive interviews of these individuals asking, how did you end up here and what was the reason you got arrested this time? Broke that then into direct effects of having a serious mental illness, which would be something like an individual with schizophrenia that hears a voice that tells them to hit someone, hit that person, and gets arrested for assault. That is, in this population, in this sample, in a very small percentage, around 4% in the darker blue. The effects of having a serious mental illness include, not being able to function at a high enough level to keep a job, ending up in the streets, homeless, very visible, arrested as an indirect effect. We see larger wedges in the study, 19% and 7%, that are related to the co-occurrence of substance use disorders. And we already talked about how highly prevalent substance use disorders are in individuals in criminal justice settings with serious illness. And indeed, in this study, it too contributed to their being arrested and being in jail. But we have this rather large two-thirds circle of other factors to explain it. So it's not simply mental illness and substance use. But what might these other factors be? It turns out that individuals with serious mental illness actually don't do well in criminal justice supervision. They tend to be part of revolving door population, and that in following over 3,000, almost 3,000 probationers for 2 years, Loudon, Scheme, and Associates found that 13% in their study was screened positive for mental illness, and that when they followed them forward, those mental illnesses were no more likely to be arrested, didn't commit new crimes, but they were significantly more likely to be revoked. Suggests there's something about having a mental illness that increases your vulnerability in returning to correctional settings. Thinking about the effect that David had mentioned earlier of mental illness as a responsivity factor. And certainly in all of these arenas, mental illness acts in a synergistic and on a negative way to exaggerate some of the problems that are associated with antisocial attitudes and personality patterns and antisocial friends and peers. It too is associated with difficulties in the bottom 4, or the green factors, the dynamic risk factors that can be addressed to explain why individuals with mental illness may be a part of the revolving door. And so we need to be thinking about how do we address both the mental illness and the dynamic risk factors to allow that individual to go forward and to move into communities, continue on the recovery path, and avoid subsequent incarceration. We've learned from studies is that other factors, wedge of the pie I alluded to earlier, may relate to this slide. It's those mental illnesses that are involved in the criminal justice system actually have more of central 8 dynamic risk factors than those without. some of that relating to the high rates of co-occurring substance use disorder, but the fact that these risk factors, the same risk factors that exist for anyone, have an explanatory role in getting involved in the criminal justice system, is present in higher rates among those with mental illness. And these predict recidivism more strongly than mental illness. I want back to the risk principle that David had highlighted earlier to address one of the central tenets, and Ruby Keselbosch mentioned this earlier. We need to do no harm as we intervene and attempt to improve public safety and public health outcomes. And evidence for the possibility of harm actually comes from a study that Dr. Ed LaTessa did in Cincinnati in Ohio several years ago, looking at their community behavioral correctional facilities. These are very expensive. They spend about $120 million a year. And at the time of this study, people were being sent to these CBCFs without any attention to what their risk levels were. And the study compared those that went through the CBCFs to those that did not. And in this slide, we saw that when you actually did separate the groups by risk, those individuals that were in low-risk categories actually returned to prison at rates higher than folks that didn't go through the program at all. Not a very good investment, not the way we want to spend our dollars. However, it was the case that when you looked at those with moderate and high risks, you actually saw some of the bang for the buck you'd expect in reducing recidivism rates. This type of information that has reinforced the concept that it is critical to attend to risk, and that if we want to get some of the impacts on recidivism that we desire, we need to focus on those individuals in the higher risk categories, and exists on a continuum. Two, mental illnesses exist on a continuum, and that they range from any diagnosable condition, which occurs at about 16% of us during the last 12 months, to those that meet criteria for serious mental disorders, about 5% of our population at any given time, and those that have more disability and meet criteria for severe mental disorders. These distinctions are based on three dimensions: the diagnosis, the chronicity of that diagnosis, the attendant disability related to that diagnosis over time, and with that disability, functional impairment, and actually has much more of an impact on an individual's likelihood of recovery and avoiding public safety difficulties than a simple diagnosis. For example, there can be individuals with schizophrenia that are functioning at high levels, teaching college courses as professors and very active and involved in the community. There can be people with schizophrenia that are able to work, find a place to live, are on our city streets, homeless and panhandling. Diagnosis itself is not the distinguishing feature, but the impairments related to diagnosis are. So, not substance use disorders are alike, and they exist along a continuum from people that don't use at all, from social use and heavy use, and at some point, use is associated with problems. And we need criteria for substance abuse. Later on, when people have lost control, are experiencing withdrawal symptoms, require larger and larger quantities to achieve the same end, they may meet criteria for substance dependence. And these are very important clinical distinctions to understand, because the way in which one would approach an individual without substance disorders or with abuse is different from those that meet criteria for dependence. So again, we've got risk along a continuum, mental illness along a continuum, and now substance use along a continuum. That was done last week, as we have mentioned, and we will tell you how to access this at the end of our formal discussion of our webinar. We took into consider these three dimensions. That is, genic risk, functional impairment related to substance use, the functional impairment related to mental illnesses. We're suggesting, as a way to think about system planning to address the needs of a population that is very heterogeneous, is use a framework that at the outset sorts individuals along the risk continuum. So that I'm presenting it, and the framework is broken into a dichotomous variable, low and high. We know it exists along a continuum. So there are valid and reliable risk assessment measures and tools that can help and assist in making this distinction, and that we hope to, in the future, assist as individual communities think of what tools they may apply and how to select them to a population going through their criminal justice door. Following an assessment of risk, we then need to understand the impact of substance abuse on signs, symptoms, and behavior of that individual. And so a screening and assessment process that sorts out individuals as having either not a problem with substances or abuse or dependence is necessary in order for us to differentiate those groups that come through. So now we've a mention of risk sorted, now on the dimension of substance use, and then the third dimension would be looking at individuals as to whether they have a current or a lifetime mental illness, what signs and symptoms are, what the diagnosis might be, and importantly, what the functional impairment related to that mental illness is. So with these three sources, or these three screening and assessment processes, we then can derive subgroups of individuals. Again, the lines between these groups are not fixed or finite. This is a heuristic device to help us think about how we address the needs of these individuals. And so on the left side of this framework, you'll see those groups that have low criminogenic risk. On the right side, those with the higher risk levels. And that how we address and what the groups within these subgroups need is subject of an ongoing dialogue. But we wanted to start the dialogue with a bit more of a understanding of heterogeneity of folks that are involved in our criminal justice system as it relates to their behavioral health needs and their risk levels. And sort of think about how we would address the subpopulations. I'll walk you through just a few examples of that at this point. We those individuals that are low criminogenic risk, that don't have significant behavioral disorders, a small group of individuals that got caught up in the criminal justice system that really should not be a priority for either treatment or supervision services out in the community. And when possible, as related to the do not harm maximum, separate from high-risk populations in programming or when under community supervision so they can move forward and gain their place within community and come back. It's into these individuals with high risk, as demonstrated in group number 5, that are involved in the criminal justice system, that we want to be thinking about more intensive supervision strategies. So, the group without significant behavioral disorders, priority for intervention that target those criminogenic needs, real priority for behavioral health treatment resources either within jail or prison or in the community. They can be referred to communities to provide reentry to address targeted low-level disorders that might arise in the future. The next grouping of individuals are those with low criminogenic risk that have a significant behavioral health treatment need. One of the requirements within our jail and prison settings is that these disorders are screened for, assessed, provided care within those settings, and it is the case upon release that these individuals won't require the intensive supervision and monitoring because they are low on the criminal risk dimension. We possibly can separate them from the high-risk population, not suggesting they don't need help, shouldn't get help, but what we are suggesting through the framework is that they should get access to the effective treatment and supports that exist within the community. I outline that at this slide because it's easier for me to write than for us to deliver on. And all of you on the phone have examples of gaps that exist or difficulties in accessing some of the evidence-based treatments and supports. But for purposes of system planning, it is out of the criminal justice system that these individuals should seek the care that they need, hopefully get access to evidence-based practices, move forward in their recovery, and likely, with appropriate actually are those individuals with high criminogenic risk and high behavioral health treatment needs, either substance use alone, mental illness alone, or co-occurring disorders. And because of their high criminogenic risk, we would want those individuals to be prioritized for corrections and community corrections, staff time and treatment, intensive supervision and monitoring, and specialized caseloads if that's available. They also are a group that are going to need access to effective treatments and supports, both mental health and substance use, within the community. We understand that they have to have interventions, and earlier slide I suggested they don't get those often in community settings, but we need to be better about providing interventions that target criminogenic needs and those cognitive behavioral strategies that are associated with reductions in criminogenic needs. And it's this group that I think exemplifies the importance of collaboration between mental health, substance abuse, and corrections and community corrections providers and administrators. It is this group that we want to come together to think about who should provide treatments, how they get funded, where they should occur, how long they should take, how intense they should be. And it really is our chance to start thinking about, with the limited resources we have, how to spend them most efficiently and effectively to get the public health and public safety outcomes that we want. I mean, my time in this last section talking about target population, so that with valid and reliable screening and assessment processes for mental illness, substance use disorders, and criminogenic risk, we can sort individuals into priority groups or subgroups and then think about what services they need and who should deliver them. There's a whole other discussion about the area on the right, the comprehensive, effective community-based services and supervision strategies that we need to serve these groups. But for the time being, we're going to stop at this point in trying to define populations and then think through how to respond to them in appropriate and effective ways. At this point, I want to turn it back over to David DeMora for some closing comments about the application of the framework and how it can help professionals in correction and behavioral health fields.
Thanks, Brad. With this framework, we've essentially attempted three goals, or three overarching goals. One, to advance collaboration and communication. Two, to ensure that scarce resources are used efficiently. And three, to promote effective practices. So the framework advances collaboration and communication in a number of ways. It helps to develop a shared language around risk of criminal activity and public health needs. For too long, we've had discussions in rooms where each of us had the best interests of community safety, of our clients, of the offender, of whatever language that we used. We had the best interests at heart. And often we were saying very similar things in terms of where we needed to get folks to. But often we were trapped by our own language, by our own viewpoint, and while we got very good at focusing at the area that we worked within, we did do a very good job in making sure that the other areas were focused on. And unfortunately, even when we did do a good job, folks would be more likely to fail because other important components were not focused on. Secondly, establishing common priorities between criminal justice and behavioral health systems. Ultimately, we want healthy individuals, we want healthy communities, we want safe communities. There's nothing that one of our systems would like differently than those things. Creating a common starting point for cross-systems policies and practices and decision making. Having the common language, understanding that we have common priorities, really starting to be able to have ongoing communication about how it is that we will develop these responses. And then underscoring the need for information sharing across systems. And this can often be sensitive, and it is not that the wrong information should be shared or that sensitive information that is privileged should be shared, but there is so much important information that we are able to share, that we should be sharing with one another, that ultimately will benefit that individual in terms of moving forward, both in terms of not recidivating and in terms of their recovery from whatever difficulty that they are experiencing, whether it be mental health or substance use or abuse. And it helps improve community safety. Help ensure that scarce resources are used efficiently by identifying the right people for the right interventions. It sounds so simple and so straightforward, but I think that many of us on this call have had the experience in our life of having a good intervention and not having a good way to get the right people there because the way that folks were referred did not really match up to what it is that the intervention was doing, or because we would take folks that we felt we could work with, but there were no objective assessments that made a determination of whether or not it was the right type of intervention, the right intensity of intervention, or the right combinations of interventions. The framework helps ensure that resources are used efficiently by promoting the use of validated assessment tools to gauge individuals' criminogenic risk and needs, together with substance abuse and mental health needs. Really looking at this in, we think, one of the most integrated ways out there, really making sure that we do not miss any of the important components that need to be responded to. And as an aside, in late winter, early spring, a next step in our project will be developing a monograph that does a review of current risk tools and looks at them both in terms of how good they are at determining criminogenic risk, but also how good they do in terms of focusing on substance use and also mental health, and what are the combinations of assessments that make the most sense. And then thirdly, encouraging collaborative decision-making among system leaders for how scarce treatment slots and intensive supervision services should be allocated to have the greatest impact. Often, even when we develop these alternatives, we don't have a good way to appropriately determine which folks should be in them. And needless to say, we have many more folks that need services than we have services, and it's best to be able to make an accurate assessment of who should go where and who needs the most intensive types of responses. And then thirdly, the framework promotes effective practices in a number of ways by, again, looking at the issue of matching individual risk and need to programs and practices associated with research-based positive outcomes, by ensuring consistency of coordinated approaches, also allowing for individualization of treatment and case management strategies. It is important to remember that we know there are a number of types of responses that will make a difference, and it's important, it is necessary that those responses be utilized. The number of the responses that are utilized, even the sequence of them, change, and that depends on the individual needs of the person that we're responding to. But there's a clear set of appropriate responses that between the systems we need to be discussing more overtly and more typically, as opposed to simply talking about what it is that our particular system can provide. And focusing reentry and other efforts for individuals leaving prisons and jails in order to equip them with the necessary skills and competencies to become pro-social, law-abiding, healthy members of our communities and of our families. We here at the Justice Center and the National Reentry Resource Center and in our JMHCP project, our Justice and Mental Health Collaboration Program, we will be utilizing this framework with our grantees in the coming year, piloting in a number of sites, and really testing it out and helping both our grantees to think about this in a better way and to get some excellent feedback. We're certain from our grantees that will help us know how to better operationalize the framework and tweak it as time goes by. Thank you all for listening, and Mariana is going to now give you a couple of final words.
Thank you much, Mr. DeMore and Dr. Osher. We will begin the question and answer session shortly, but we have received a number of requests on where the report report is found. It is available currently on our website at no cost to the public. There's an FAQ, a frequently asked questions document, as well as a summary document in addition to the full report. Are downloadable at the address here on the slide. We'll now begin the question and answer session. We have a number of questions coming in from the audience, and I will do my best to have our presenters answer as many as possible over the next minutes, the time remaining, and I will be moderating as we move forward. So the first question I have is for Mr. DeMora. Are you there?
Yes.
Okay, great. So I have someone asking, are interventions for high-risk/high-need individuals an ineffective use of resources?
No, not at all, actually. First thing is that what we know from the research, is that the best bang for the buck in terms of interventions are really focusing on moderate or high moderate and high risk individuals. They are in fact not destined to be failing in treatment. They do respond well to the appropriate interventions. When you're talking about evidence-based substance abuse and mental health treatments and you combine those with research-driven corrections supervision, you can indeed reduce new criminal acts in the days that folks spend in jail or prison for different types of offenses. Now, the fact of the matter is that while high-risk and high-need individuals may spend more days in jail or prison than the low-risk groups within a program, they have better results than those same high-risk, high-need folks who did not have integrated interventions. Translation in terms of all of that. When we compare a bunch of folks with high risk, high need who get the appropriate intervention to those who don't, we find a significant difference in terms of their recidivism, as Fred was showing earlier with the study from Ohio that Dr. Latessa and his colleagues did. Even equally interesting, I should say, is that very often we spend a lot of time, a lot of resources, a lot of money on the low-risk individuals, and even if we don't harm them, which unfortunately in some cases it appears that we do, even if we don't harm them, there really is no return on investment. And so if we're worried about, in an ineffective use of resources, if we're worried about wasting money and if we're worried about actually increasing risk, we need to actually pay much more attention to moderate and high-risk individuals and provide significantly less intense intervention for folks who fall into the low-risk categories.
Great, thank you. We have a question for Dr. Osher. It is, does the framework suggest that behavioral health care services be prioritized for adults on probation or parole over adults with no criminal justice involvement?
A good question, and it certainly is a concern of many family members, that have difficulty accessing care and hope that they don't have to have their loved one get arrested in order to get the treatment that they need. The framework is not sort of suggesting that there be a priority for people within the criminal justice system over those that aren't. The historical mission of substance abuse and mental health providers and agencies in this country have been to serve those individuals with behavioral health needs, often those higher needs getting more ready access to the more intensive services. This is simply for those individuals that are under correctional supervision. So it's those individuals with mental health and substance abuse needs that have found their way in the criminal justice system, not under supervision, and how should they be triaged in a way that allows them to get the care that they need. One of the things that occur in criminal justice settings, as I mentioned earlier, is that screening and assessment happens. And so an old mentor of mine suggested that this actually is a public health opportunity. Some individuals may never have had an assessment that identified either substance use and or mental illness. And now coming through criminal justice doors, having had it identified, even at low risk, low criminogenic risk, those folks now should be referred to and sent to the public providers that can address their behavioral health needs. So in no way is this to suggest that criminal justice involvement is a go to the front of the line card. It is for those individuals that are under correctional supervision. How do we think about using the scarce resources that are dedicated within criminal justice settings to address behavioral health needs, and when they leave and go into the community, how do we make sure that those resources leverage the care and treatment that's available?
Great, thank you. We have another question for Dr. Osher. It is, given any budget cuts, what changes are possible with limited resources?
Yeah, thanks. I'm sure any one of us on the phone could have written that question and really understand and impacted by shrinking budgets, both on programmatic side in corrections and in the delivery side on mental health and substance abuse. So these are difficult times in terms of making sure that we use our scarce resources as efficiently and as effectively as possible. The framework exists for an independent of fuel. I like to use the metaphor that the framework helps lay the track. Hopefully it's going in the right direction. And that in a period of scarce resources, you have to allocate them across risk levels and by need. When more resources become available, the fuel is more. You can move that track perhaps a little bit quickly, expanding the groups of individuals that might be eligible for care that does get specialized services. So framework is independent of resources. I certainly appreciate, as a provider myself, the climate that we operate within. What I want to make sure is that we have direction, that we're all moving in the same direction, so that when we get resources, we can use them efficiently and effectively. Thank you.
Great, thank you, Dr. Osher. One of you asks, can you apply the framework to both men and women? Would you like to take this one?
Sure. Fundamental framework concepts are effective for both men and also across racial and ethnic groups. Having said that, the pathways into the criminal justice system and recovery really do vary across populations and across gender. For example, women's incarceration is more likely related to harmful relationships and to trauma than is men's. Gender-informed assessment tools have been shown to be very effective in identifying these and other related needs. You don't simply use the same risk assessment tools on men and women, for example, and even in some instances where you might use a core part of a tool that you use in terms of both men and women, there are addendums or add-ons that you would also use in order to have an accurate assessment for women. The framework very strongly advocates that people use the most appropriate, most appropriately validated and reliable assessments for particular populations and settings to help inform case management plans and treatment. Even when you have a tool that has validated in terms of it's developed and validated in a central place, very typically each locality will want to validate that tool based on their particular area, whether that's a state or typically a state, but sometimes a county as well. Unfortunately, there's relatively little research on whether interventions have different results specifically based on race and ethnicity of individuals that are under correctional control. At the time, behavioral health research has clearly identified gender, race, and ethnicity as very important factors to consider in relationship to responsivity. So it holds that they should cross over in terms of our correctional thinking as well. Programs that attend to these factors may indeed have much more impact on their participants than those that don't. We have to basically acknowledge that there's these different issues. We have to acknowledge that they can be critical when we're addressing the criminogenic needs of individuals. The most important thing is that agencies really build their competencies in terms of investing in staff training, examining the cultural sensitivity of particular practices, and really attempting as best as possible to purposes that are responsive to individual needs, individuals' cultures. The reality is that we routinely fall short in this, but the more that we focus on it, the more that we're conscious of it, the better off we are, and hopefully several years down the road we'll have some much better evidence than we do now to guide us in terms of which specific road to make the most sense, or specific pathways make the most sense in terms of different interventions, particularly for different cultural groups.
I just to add on to David's answer, because I saw it come up in a queue of questions here. People were just asking, well, what about the impact of trauma? How does that affect the framework or the groupings within it? And in a similar way to what David was discussing, we certainly are aware of the high prevalence rates of trauma, both men and women that are involved in criminal justice settings, and we need to assess for its impact. There may even be criteria met for post-traumatic stress disorder, and build into our responsivity approach so that we deliver with an understanding of the impact of trauma interventions that are specific for those individuals that require that. We seek to create trauma-informed systems of care to avoid re-traumatization when possible. And so it's mental illness issues that become part of our understanding of responsivity and how to assure that we deliver the best and most appropriate intervention in a way that can be used by the individual that it's targeted to assist. I guess also through the queue of questions, there was a question about cognitive impairment. Does the framework anticipate, working with individuals that have difficulties in thinking, reasoning, maybe intellectual capacity? It becomes another responsivity issue. So we have to understand how that individual thinks, what they're capable of, and then accommodate to it in the delivery of our intervention so that we are responsive to their own unique individual characteristics.
Thank you both. We have a few programmatic questions. This one is Dr. Osher, you can maybe stab at this. It is, how does the agency pick screening and assessment instruments?
That is an excellent question, because certainly the heart of the framework that's been described is the utilization of valid and reliable screening and assessment tools. And that there are a lot of them that are out there. And as David suggested, we hope to provide a review of what we know about which of them are valid and reliable for which subpopulations going forward. But there are a lot of factors for an agency to consider in selecting screening and assessment instruments. So it's related to the time it takes, the training requirements, the cost. Some are public domain, some are proprietary, what they measure, and how valid it is for the population that you're working with. There are a number of reviews out there of instruments, and that it is going to be incumbent on sites to think about what's being used by other providers within the system. You might choose an instrument because the state patient office has decided to use that instrument. You might choose an instrument because there's no cost involved in it. It's really important for us to understand the distinction between screening instruments and assessment processes. So a screening instrument is an attempt to answer a yes-no question. Might the individual have a mental illness? Yes or no? May they have a substance use disorder? Yes or no? Are they a risk individual? Yes or no? It's the follow-up to those screens that are critical, and everybody wants to know, well, what's the best assessment instruments? And while there are instruments there, I think it's important to remember that assessment is a process, not an event. And so the process of gathering up, collecting information over time from a number of sources so they can have increasing confidence about the area that you're evaluating. So you can come to a most reliable conclusion about the type, the nature, the requirements for treatment of a particular set of needs. So I wish I could say use screening tool A, B, and C along with assessment D and F and you'll be there, but it's a little more complicated than that. On the other hand, screening instrument that's reliable, it is better than not using one. And so selecting among the group that's out there, I often say it's better to use an instrument than no instrument. And there'll be a lot of factors, as I mentioned earlier, that go into the decision process, and it's a topic for ongoing conversation, but I appreciate the nature of the question.
Great, thank you. We have time for one last question, which I think Mr. DeMora can take, which is, how does this framework apply to sex offenders?
The short answer is partially. Folks who've committed sex offenses really typically have, one or more of the core criminogenic risk factors that we've been talking about, right? Antisocial thinking or antisocial cognitions, substance abuse issues. Very significant number of sexual offenders have very significant substance abuse issues, particularly among rape offenders. Easily over 60% of them. Many of them have marital or family relationships, and so, not surprisingly, into those core criminogenic issues and the substance abuse issues, many of them have some significant concomitant mental health difficulties. While they don't have as high an incidence of serious mental illness as we might see in some other populations, they certainly have a very significant incidence of general mental health difficulties. And, therefore, when we are doing an evaluation of somebody who's committed a sex offense, it is important to utilize the general tools or the regular tools that one would utilize across the board for folks who are coming through the system. So you want to do a good criminogenic risk screen. You want to do a good mental health screen. You want to do a good substance abuse screen. You should be doing that with sexual offenders just as with every other type of individual that you see who's coming into the system. We then have to do on top of that or add some of the specialized risk assessments that have been developed only for sexual offenders. And some sexual offenders will, if you will, hit high on all of these types of screens. Some of them will hit low on a sex offense screen and high on a general crim risk or mental health or substance use screen, or they'll look very good in terms of general criminogenic risk but score very high on a sexual offender risk assessment. So it's important to understand that when you're dealing with sexual offenders, it doesn't mean that you throw out everything else we know about folks that are in the criminal justice system. It means that on top of that, you need to add some additional specialized types of assessment as well as obviously treatment responses. And as Fred was suggesting earlier, really there is no person who comes to the system that there is one type of screen or one type of assessment tool that will answer all of the questions that we need. The question to answer really is what's the best package to use, or what's the best package that we can use in our particular area, depending on, again, resources, training of staff, dollars in terms of cost, etc. There you go.
Thank you so much. So I think we're going to conclude the webinar here. I would like to thank you all for your attendance and participation, and thank you to the Bureau of Justice Assistance for sponsoring this event. And I would like to extend a big thank you to all of our presenters. A recording of this presentation will be available online early next week on our website, www.consensusproject.org. Finally, when you leave this event, a brief survey on this webinar will pop up on your screen, and we very much appreciate your feedback. Thank you, and we hope to see you again soon.